Good afternoon, everyone. Welcome back to another session of 2020, Trendo 2020. Uh, right now, we are going to have the product theater. This is being chaired by Dr. Rajesh. Dr. Rajesh Rajendran is a consultant diabetologist and endocrinologist at Raja Rajendran Hospital, Chennai. He's an excellent academician and clinician. He has done his training in internal medicine and diabetes and endocrinology in UK. He has over 18 years of experience and he has worked in several reputed NHS in England and Scotland. He has various publications and he has authored several chapters in various published books. He's also been a recipient of several awards. Welcome, Dr. Rajesh. Please introduce the speaker.
Thank you very much for your kind introduction. I have to say I am honored to actually introduce our speaker today, Dr. Krishna Seshadri. He actually needs no introduction at all. Uh, I think all of you would have heard about him. He is a reputed international authority in endocrinology, and his merits and achievements cannot be actually compressed into one slide. But nevertheless, he is a board certified endocrinologist with many years of experience and pearls of wisdom. And he is our current Endocrine Society of Tamil Nadu president. And he's the editor in chief of Thyroid Research in Practice and the associate editor of Journal of Diabetes in Developing Countries. As I said, I'm very proud to actually introduce him because he is considered as a guru to all of us. So today, hopefully, he will be able to enlighten us, and it hopefully is also a case-based discussion in this symposium today. And I'm hoping also to learn from Sir a lot about this topic and optimizing the combination of SGLT2 and DPP4 in type 2 diabetes. So without much further ado, I'm hoping that Sir will take over and start. Thank you.
Can you see my screen, Rajesh?
Yes, I can see your screen, sir.
Thank you so much. Thanks for the opportunity. Remember that this is an industry theatre, and therefore I have several conflicts of interest that include speaking on an area, and the support slides for this particular session have also been sourced from the sponsors. So we should expect fair degree of conflict. Having said that, let us look at this carefully. That diabetes, despite multiple therapies, majority of patients have uncontrolled A1C, and across the world, irrespective of whether you practice in an Ivy League organization or in a small clinic like I do, your greatest frustration is having patients with A1Cs that are fairly low. Several reasons for this, including that this is a chronic disease, and it's nigh impossible for people to be following your recommendations as they would do in a clinical trial. At the time of diagnosis, about 50% of the beta cell is already lost, and if you were to believe Dr. DeFranzo, it would be 80%. But the A1C is attained or a target of 7% in about 13.5% in the South Asian population or Southeast Asian population. But remember that this is true across the world. There are several issues that we have in front of us, and we have talked about clinical inertia, Dr. Kunti's work over a period of time. One of the ways that people have talked about is one size does not fit all, that every patient is unique, that you don't set an across the board target, you work based on the comorbidity, their ability to achieve it, whether they have life-threatening hypoglycemia. Second is, of course, is to think about using early aggressive therapy that includes insulin and injections. The third is to not to sort of give into the inertia by saying, let me give you 3 months of diet, and you come back and say, wait, like Kalyan and doctor, there's a marriage there, My daughter was going to the US. So what do? Is you say, you know what, let me start you on drugs right off the bat. And while this has also started, despite what the guidelines say, many of us have started using 1, 2, or 3 drugs at the time of initiation. And there are reasons for this. It's not just something that is done by the whim of practice. If you have HbA1c in the first year of diagnosis, there seems to be a dysglycemic legacy, meaning that there is an increased risk of complications when the glucose is high in the first year of diagnosis, especially in the long run, right? The second thing is that over a period of time, that this glycemic legacy continues. Let us look at this patient. You will find in subsequent slides that he has been named Vijay. He is a corporate executive, and I always wonder why all these clinical studies have corporate executive. It's just to take away that thing about cost of therapy. The non-smoker, 49 years old, his stomach looks like mine, diabetes for 2 years, hypertension for 6 years, metformin 1 BE. He's on amlodipine plus telmisartan, and his A1C is 8.6. His obesity is obese, right? So if you want to individualize, and this is based on the ADA algorithm that was present, what you will notice is that here is someone who has a very low risk of hypoglycemia adverse events. He's newly diagnosed. His life expectancy is fairly good. He has no important comorbidities. He has no established vascular complications and seems to be fairly motivated. And of course, he has good resources, as we talked about. Here is someone whose horse is still in the stable. It's not bolted. You really want to be saying, you know, let me get this to 6.5. I want you to also remember that 6.5 is not a normal A1C. Normal A1C for this population is anywhere between 5.6 and certainly less than 5.8. And so clearly, when we talk about 6.5, that is also a compromise, right? And here is someone who's 8.6, and you really want to be getting him as near to normal as possible. From the look ahead trial, we know that diet alone is not going to be doing this. And certainly a single drug like metformin added to diet is also not going to do this. You really want the A1C to come down. You really want to have 2 and maybe even 3 drugs at some point. This says what should be your approach after metformin. Many of us would say, you know, you would even start, if this patient was on metformin and he's on a maximal dose of metformin, what should you ask? What should you add a single drug or should you add 2 drugs? And now that a combination of 2 drugs are now available, should we use a combination? Remember that achieving a glycemic target through a single agent is difficult to achieve. The glycemic control tends to decline over monotherapy, and this is from the UKPDS 49. And at about 3 years, only about 50% of patients were adequately controlled in sulfonylureas in the UKPDS. And by 9 years, clearly less than 24% of this group. And this is without the clustering that we've now heard so much about. Simply because there are also other reasons besides the pancreas that cause worsening of glucose, that include lipolysis and increased glucagon, change in the muscle uptake, the kidney contributing by glucose reabsorption, and of course the incretin effect. Not to forget that the brain is not just the most important sexual organ, it's also the most important glycemic organ, right? So a single organ drug does not correct all the pathophysiologic disturbances present in type 2 diabetes. While metformin works with hepatic glucose production and glucose uptake, you really want to be adding other drugs. Sulfonylureas work through insulin secretion. The DPP-4 inhibitors have a myriad methods of action that include the pancreas. And of course, now we know that the SGLT2 inhibitor works at the level of the kidney. It may have some other effects on it. In many ways, that there is now the option to sort of combine agents so that you address multiple pathophysiologies of type 2 diabetes. And so there is a lot of data that that is finally made to the standards of medical care, that there is data to support initial combination therapy for a more rapid attainment of glycemic goals. So clearly, and remember that 1 plus 1 is never 2 when you combine drugs. It's usually 1.2 or 1.3, and there are formulas available to tell you what will happen when you combine 1, 2, 3 drugs. But clearly, in someone in whom you need to bring it down by more than 1.5, besides the diet, you need 2 drugs. So a combination of 2 drugs that have been really hitting the headlines for the last 10 years seems to be something that is very in up the up thing to remember that sulfonylureas are still a very good choice for therapy. In the presence of ASCVD, in the presence of heart failure, the SGLT, and in the presence of obesity, the SGLT2 inhibitors become naturally selected agents where you want to minimize hypoglycemia and especially in the elderly, a DPP4 inhibitor is something very useful. And remember, the combination has certain benefits that we will talk about. So when you want to think about this person, you want to have metabolic control, you want to get his weight down, you want to prevent complications, and of course, you want to take into account some of the specific and patient factors. When you combine 2 drugs, for example, here you combine empagliflozin and linagliptin, in a metformin background, you will find that there is, as I said, 1 plus 2 is not 1 plus 1 is not 2, but certainly you would see an A1C reduction that's around 1.2, 1.3. Not much difference between the 25 and 10 empagliflozin, so you could use either of, and I've seen people do various shortcuts to reduce the cost. And this is looking at an A1C of 8, which is somewhere close to where this patient is. And looking at the combination here, you will see that's here in the green. This is 25-5 and this is 10 and 5. And you'll see again the 10 and 5 doing well. Again, going back to my old theory about in both Vertus and the EMPA saying that the 25 probably drags the 10 down. And you will notice that this is what you see, that the A1C has dropped down from 8, and in about 10 weeks, you're seeing a nadir of 6.8, 6.7, as close as you can come in drug naive. And you see that even with the metformin background, you have similar results. There is weight reduction that is largely attributable to the empagliflozin and the linagliptin. The blood pressure reduction and diastolic blood pressure reduction are all consistent with the empagliflozin add-on. So here is just some more stuff that you see. Yes, some signs of left ventricular hypertrophy. LVEF is 55%. The urine albumin creatinine ratio is 200 and EGFR is 75. And there you see the other studies coming in. Remember the DAPA-HF, the EGFR, the DAPA-CKD, the EGFR was between 25 and 75 and showing benefit. But remember that as far as the echo is concerned, that HEF versus HEFREF is a question. Simply the presence of UACR gives you that an indication to add an agent, not only an ACE inhibitor on ARB, but especially if the UACR is elevated, the EGFR is low, you would think about adding SGLT2 inhibitor. Remember that DPP4 inhibitors, especially linagliptin, has been shown to reduce UACR, but not the long-term outcomes of this. Just to sort of put these two together and see if they work well together. Remember, you're comparing apples and oranges. You're really not comparing apples and apples or donkeys and mules. Here you see the EMPA-REG outcome. You will see the upper limit of the confidence interval being 0.99. The only study where CHT reduction was also seen. Canvas also showed a reduction in the primary MACE. None of the others did, but remember that these were at least safe, and together there is benefit. This is Vertus CD versus NT-COS, pretty much looking the same. Again, remember that the EMPA-REG and Vertus CD had pretty much the same population, but with completely different results. And this is looking at CV death outcomes, and the EMPA-REG outcome was the only one where there was cardiovascular benefit. None of the others showed that kind of superiority. When you come, so clearing empagliflozin with linagliptin seems to be something that hopefully the combination gives you the benefit. Remember that saxagliptin had a higher incidence of hospitalization for heart failure. You didn't see this with with declaratomy. Examine, of course, is not, allogliptin is not available. And of course, TCOS was banned. Middle, it did not show an increased risk of heart failure. Having said that, the FDA advisory about heart failure for all the DPP-4 inhibitors, not a black box warning, seems to be still in fact. So when you look at this in terms of renal composite outcomes, again, Vertis-CV did not show the benefit, but all the others did show benefit. Again, exploratory in most of these, except in Credence, where there was clearly benefit because that was designed for it. And of course, DAPA-CKD, where between an eGFR of 25 to 75, there was benefit. In terms of Carmelina, remember that this again was non-inferior, but there was benefit in terms of UACR. This is the Emperor reduced study that looked at LVEF less than 40%, as I talked to you about, an eGFR that is greater than 20 mils. And you will notice that the primary endpoint was adjudicated CV death with heart failure hospitalization was superior. The upper limit of confidence interval was 0.86. And the eGFR slope was 1.73 mils per minute per 1.73 square meters, which is significantly better than what you would see normally, a slope of close to 4 to 4.5. So this is looking at dedicated renal outcome trials in addition to the SGLT2 inhibitors. And you will notice that Credence and DAPA-CKD, the populations were slightly different. But the important thing to remember is that in terms of the heart failure and renal failure, as a class, these drugs do amazingly well. Remember that EMPA-Kidney looked at a broader population than Credence itself, but it is interesting to see that across the spectrum there seems to be benefit. This is a Credence population, eGFR of 30 to 90 and UACR greater than 900. DAPA-CKD 25 to 75, UACR greater than 200. EMPA-CKD eGFR of 25 to less than 45. And an eGFR of greater than 45 to 90 with a UACR of greater than 200. Remember, the EMPA-Kidney, you didn't have, in the 20 to 45, UACR was not a requirement. So the albuminuria benefits, as I talked about, is a 14% risk reduction in terms of progression to albuminuria, and of course, importantly, a 15% reduction of regression with albuminuria. Again, interesting and something that we can add as a plus point, but certainly not something that you want to extrapolate in terms of renal outcomes. But together, they don't harm. So let's put this together in terms of guidelines. You'll realize that SGLT2 inhibitors, CANA, DAPA, are recommended in patients with type 2 diabetes and CVD at very, very high risk of CV risk. And empagliflozin is recommended to reduce the risk of death. So the mortality benefit that showed in the EMPA-REG trial showing up. And remember that the ESC was looking at it even without metformin. And to reduce heart failure, any of the SGLT2 inhibitors, you have a class 1 level A. And they say that the DPP-4 inhibitors, SITA and LINA, are neutral. Remember that SAXA has that. So this is looking at cardiovascular and renal outcomes with the individual agents of the combinations. This is empagliflozin and linagliptin, reduction in 3-point MACE, CV death, heart failure risk, and renal. This is dapagliflozin, remember the saxagliptin sitting in there. And we don't have the combination of ER2 with SITA, ER2 with SITA in India, but looks like these are neutral. So what do you want to do? Clearly, you want to achieve metabolic control, you want to prevent complications, and what you will find also is that there is no increased risk of hyperglycemia. And very interestingly, and there are several theories to that include, DPP-4 receptors in these candida, these genital fungal organisms. You will find that there is a lower incidence of genital tract infections when you add a DPP-4 to an SGLT2 inhibitor. And this is just showing better safety when you combine the two and lower genital infections. And so here you have metabolic control, prevention of complications, and of course, lower genital infections. This is where our patient is. He has hypertension, he has diabetes, he has obesity, he has structural heart disease, He has microalbuminuria, and you can prevent him from progressing here. Remember that the data is still class 2, level 2. But clearly, the combination is useful. An 1.8% reduction in A1C that we saw, reduction in weight and BP, and you will find that there are some mechanistic benefits that you see. In established ASCVD, there is clearly benefit. This person does not have established ASCVD. There is albuminuria benefits, but there is also data to suggest that reduction of albuminuria improves outcomes. So to summarize, I'm sorry for the background noise. Optimizing benefits of a fixed dose combination addresses multiple pathological mechanisms, produces robust A1C reduction, low hypoglycemia risk, decrease in weight, BP, albuminuria, improves vascular function. Improved vascular function is question mark. There is evidence whether it applies for this patient is a question, but clearly it doesn't hurt. Empagliflozin causes mortality benefit in the patient with established ASCVD. This patient does not have established ASCVD, but clearly in someone with established ASCVD, there is clearly there. And of course, benefit in terms of heart failure. But the most important thing is getting two drugs into one that reduces both weight, that brings glucose control, reduces hypoglycemia. And remember that the cost of the two is lower than the cost of 1 + 1. I think for most of our patients who ask, kitna data hai, this makes a lot of difference. So I'll stop here. Sorry for that disturbance that came toward the end of my talk. And I'm happy to take any questions. Rajesh, back to you to continue to moderate this session.
Thank you very much, sir, for this very enlightening session. I have a question myself, sir. In your clinical practice, how good are patients in terms of compliance with this fixed drug combination? It is the combination of empagliflozin and linagliptin.
So the simple thing goes that the compliance for one drug is always greater than two. The important thing is that is the motivation. Diabetes is a game of numbers, but patients don't feel symptoms most of the time. The greatest motivation for a patient to take a drug is when the doctor spends enough time and tells him that this drug is important for him. The drug is not added just because the doctor feels it's stylish to do it, but he or she feels that it's important to do it, is able to discuss with the patient and convince him that in the long run this drug is going to help you. Given that particular time, the compliance is very, very good. Remember that the compliance with DPP-4 inhibitors has actually been one of the highest in the world, simply because these are no problem drugs. The SGLT2 inhibitors have good compliance, but have genitourinary infections. So one of the things that the FDC does is it packages it with a DPP-4, which are really good drugs. And together, I think they are very good. I haven't had issues with the thing, and especially because when you add the two drugs, the cost of the drug is also not as high.
Thank you very much, sir. I have one more question, sir. There is a lot of talk now in non-diabetic forums about the use of SGLT2s for patients with heart failure. And I have seen a number of cardiologists advocate that as well in non-diabetic patients. What are your thoughts on that, sir?
Oh, absolutely. I think the data is very, very clear. The data is very, very clear that this may probably become one of the first drugs in heart failure. In fact, I have a feeling that it's going to be better than sacubitril/valsartan, and probably may even supersede diuretics in heart failure. The question, of course, is HFpEF versus HFrEF. But in HFrEF, the data is very, very clear. In HFpEF, the data is not clear, and the indication that we have from these smaller studies is probably not so useful. So I think this is going to be going to move up very, very quickly in the cardiologist armamentarium. And it's also a great thing for us as diabetologists, is simply because that it brings to us the focus of cardiometabolic renal medicine. That for the first time we have drugs that address the heart, the kidney, right, and the other parts of the metabolism, and increasingly we need to learn more about these to get involved in the management of cardiovascular patients. So, in many ways, that this is a new chapter in the history of diabetology. This increased focus on cardiorenal metabolic medicine, and that's what this class of agent has done. It has refocused our attention to the complications of diabetes. So this is an exciting time, and the cardiologists are right in what they're doing.
Thank you very much, sir. If the audience has any questions, I will wait for them to actually post any questions in the chat box or ask.
We are really in siesta time here, aren't we?
I think at this point, there are no further questions. Your talk was excellent, sir. It was very clear for all of us. Thank you very much. And as I said, we are always keen to learn from your talks. Thank you.
Thank you, and I will meet you at the oration this evening. Hopefully, it will be something that we can all discuss over a period of time. Again, thanks to the Pondicherry team for such a wonderful job, and thanks to all of those who have tuned in. Have a good afternoon. I will join. I have another quick meeting to join, but I will join back shortly. Thank you so much, and over to Pondicherry and